Now we'll discuss a few screening considerations as it relates to the geriatric population, including screening for polypharmacy, for falls, abuse, depression, and dementia. In regards to polypharmacy, we know that as we get older, oftentimes individuals are taking multiple medications, and there can be interactions between those medications or side effects that are affecting our patient. So a few follow-up questions to keep in mind for medication use include, is one physician managing your prescriptions? Why are you taking these medications? Have you taken these drugs today? For instance, sometimes a patient may say, I only take my blood pressure medication when my heart's pounding, that they don't necessarily take it every day. And in this case, again, we have to be careful not to overstep our boundaries, but we can encourage the patient that it's important to take the medication as their doctor directs, which typically for a blood pressure medication is not just only when they feel symptoms, it would be daily in order to manage their blood pressure. Another question includes, do the medications relieve your pain or symptoms? If yes, how soon after you take the meds do you notice an improvement? When did your physician last review these medications? And are you taking any medications that weren't prescribed for you? So again, the concern here would just be for drug interactions or potentially inappropriate uses of their medications. And it's not that we would necessarily need to screen every single patient in this regard, but just kind of keeping an eye out for individuals that we may be concerned are potentially experiencing some side effects due to medications, or that they may need further counsel from their physician. In regards to risk assessment for individuals that are a fall risk, there are a few follow-up questions that we can include as well. Do you have any episodes of dizziness? If yes, does turning over in bed increase or cause dizziness? In this case, may indicate that a patient has BPPV, and that could be treated by a physical therapist. Do you have trouble getting in or out of bed without losing your balance? Can you get in and out of your bathtub and shower? Do you avoid walking on grass, curbs to avoid falling, grass or curbs to avoid falling? Have you started taking any new medications, drugs, or pills of any kind? Have there been any changes in the doses of your regular medication? Again, medications can increase an individual's fall risk if it is impacting their ability to balance. So we would want to keep that in mind. So these are just some questions that we could potentially add. And then in regards to other assessments, you've learned several in your other classes that you can utilize in regards to outcome measures to determine if someone is a fall risk. So the BERG, the Timed Up and Go, the functional reach test, as well as using things like the activity-specific balance confidence scale, could potentially be other options that you can utilize to assess for a fall risk. In regards to elder abuse, we want to be alert to the signs of that and make sure that we refer or contact the appropriate authorities in the event that we are concerned a patient may be being abused, an elderly patient may be being abused. If we note that the patient's had multiple trips to the ER, depression can be of concern, obviously not just by itself, but in the presence of the rest of these or several of these signs and symptoms, or warning signs, falls or fractures, bruising or suspicious sores, malnutrition or weight loss, pressure ulcers, noting that they change therapists and physicians often. This can be because they're trying to avoid, the caregiver may be trying to avoid being detected. So they may change physicians or physical therapists often. And then also being alert to the fact that confusion could be attributed to dementia. So they may be making comments to the therapist, and the caregiver may be encouraging the therapist to kind of blow those comments off because the patient may have dementia. So we just want to keep those things in mind. And if we recognize any of these signs and symptoms, making sure that you contact your boss or superior and determine the appropriate next steps in regards to who needs to be contacted. In regards to depression, there's a specific outcome measure called the Geriatric Depression Scale that can be utilized in order to screen geriatric patients for depression. And what's important to me is that you know how to assess the score. and interpret the score. So it would indicate that a score of greater than 5 is suggestive of depression. A score greater than or equal to 10 is almost always indicative of depression. So pretty much if we have an individual scoring over 5, that should warrant some type of follow-up assessment or referral to their primary care provider. The standard mini mental state exam can be utilized in order to assess for the cognitive status of our patients. So it can help to detect dementia that may be present as well. Again, what I think is important is that you understand how to interpret the scores. So take a moment to pause here and review the scores that would indicate severe cognitive impairment versus moderate cognitive impairment versus mild cognitive impairment. So any score greater than or equal to 27 would indicate normal cognition. And take a moment to pause here and review those others. Okay, lastly, we're going to finish up with some post-surgical considerations in regards to screening. So some things we're going to talk about are DVT, PE, and you guys, we've already kind of beat that into the ground, so I'm not going to return to that here, but just recognizing that we have an increased risk for DVT and pulmonary embolism in our post-surgical population. So that needs to be kind of on our radar. So that's why I want to include that here for completeness. But we also need to be alert to being able to screen for infection, as well as acute compartment syndrome. So in regards to infections, this is probably an outdated statistic, but about 35,000 infections occur every year after orthopedic surgeries. So it really is important for us to make sure that we're monitoring that surgical site for any changes, as well as if the patient's just telling you that they just overall just kind of feel bad or don't feel like themselves, that can be a sign that they have an infection as well. Risk factors include smoking, diabetes, heart condition, weakened immune system, individuals that are older, if there's a foreign object in the wound, poor nutrition, as well as obesity. So what are the signs that we'd be looking for? A fever would be a sign of infection, but it is important to recognize that it's not uncommon to have a slight fever immediately after surgery, just from the inflammatory response that's occurring in response to the surgery itself. So a low-grade fever in the absence of the rest of these signs and symptoms would not call for referral alone. So it's important to kind of recognize that and share that with the patient. But if an individual kind of spikes a fever that's a high fever initially, especially in the presence of other signs and symptoms, or let's say even a few weeks out that they spike a fever, it's more common for those infections to occur earlier in the postoperative phase, but it could be weeks out that they're experiencing an infection. So if we're seeing that they're reporting increased pain, if there's a lot of erythema and warmth, so a lot of redness and warmth, if we see discharge from the surgical incision, that's of concern, especially if it is, if it looks pus-like, swelling that's excessive, red streaks, as well as an odor. All of these things are concerning. In regards to redness, you are going to, again, have redness and swelling after surgery. So you just want to make sure that you're monitoring that. And if it's getting worse, then that would be of concern. One way that you can monitor redness, if you're concerned about that with a patient, is to take a pen and outline the area. And that way you can determine if it's spreading if you monitor it over the next couple of days and have the patient monitor it over the next couple of days. So again, we just want to be alert to these signs of infection, and also we want to make sure that we include this as part of our patient education to ensure that our patient is aware of the signs to look for and to contact their physician as soon as possible if they were to recognize any of these signs and symptoms. Acute compartment syndrome occurs either from a history of trauma or a crush injury. So surgery can be considered trauma, but we can think of any other type of like a motor vehicle accident, a crush injury in the sense where something actually falls on the patient and crushes a particular area, specifically in the limbs, would be of concern. What happens is whenever an individual has a trauma and they get that increased pressure in a compartment of a limb, it can result in insufficient blood supply to the nerves as well as the tissues if it persists. So the clinical presentation typically is going to be severe, persistent leg pain that's intensified with stretching applied to the affected muscles. Keeping in mind that this can also occur in the upper extremities as well with a crush injury or some type of trauma. Swelling, tenderness, and palpable tension, as well as paresthesia, paresis, and pulselessness. If we suspect that an individual has acute compartment syndrome, that is a medical emergency that requires immediate surgical treatment. So oftentimes the fasciotomy would be what would be performed in order to allow for the pressure of that compartment to return to normal and to spare the nerves and the tissues in that compartment. Some common causes of acute compartment syndrome include tibial or forearm fractures, ischemic reperfusion following an injury, hemorrhage, vascular puncture, intravenous drug injection, casts, prolonged limb compression, and again, crush injuries or burns. So to finish up this content, I want to share with you a case study of a colleague of mine that I worked with when I lived in Greenville when I was working at ProAccess Therapy. So Jackie agreed to let me share this with my students, and I've shared this every year because I think it's just a great example of how important the therapist's role is in being able to detect acute compartment syndrome as if it presents itself in a post-surgical situation. So this occurred back in 2013, and I'm going to kind of walk you through the background and history. So this patient was a post-operative patient, and they had an HTO, which is a high tibial osteotomy. And you can see here in the image, what happens in a high tibial osteotomy is that a wedge of bone is cut out in order to allow for realignment of the lower limbs. So basically, this is utilized if an individual has early stage osteoarthritis that's only affecting one side of the knee, either the medial compartment or the lateral compartment, depending upon if they are in a position of increased varus or increased valgus. So basically the HTO is designed in order to take someone, if they have an increased varus position, it is designed in order to cause realignment to bring them closer to neutral in order to offload the compartment of the knee that's being overloaded and ultimately seeing some early degeneration. So, kind of think back into kinesiology, and if we had a patient that had excessive knee valgus, let's just say we had a patient with excessive knee valgus, in that case, they're going to have an increase of compression in the lateral compartment. So in that case, the goal would be to take the compression off the lateral compartment and kind of equalize it so that there's much less compression in that compartment that would result in further breakdown. In this particular case, this patient had a medial opening. So it's kind of the opposite of what you see here. The wedge would be occurring, opening up to the medial side. And they also had some resurfacing as well to that compartment. So what Jackie had already known was that she was expected to see a very, very painful patient because he'd been calling over the weekend, and it was expected for her to see a leg that was going to be very red, very swollen, and that he'd be very painful, but that wasn't very normal for the surgery. And given that I've seen several of these patients, I will tell you, in regards to the knee surgeries that I have seen post-operatively, these individuals are miserable. They do have a lot of not only knee swelling, but lower limb swelling and redness. So it's not unusual for them to present the way that's described here on the slide. So Jackie, this was the first time that she'd ever seen a patient with a high tibial osteotomy, and she actually had to step in to see this patient because they were supposed to see another therapist the day before, but he called out, called and canceled the appointment because he was in so much pain. And so he was coming in the next day and was placed on her schedule because the original physical therapist that had been treating this man prior to the surgery had called out sick that day. So again, she was told to expect a very painful patient. And she said that that he had been checked out and the incision in the leg were going to be, when he checked out of the hospital, that the incision and leg were red and that he would be very painful, but again, that was considered to be normal. So in regards to history and clinical presentation, the patient's pain kept him from ambulating with crutches. So he basically came into the clinic in a wheelchair. He reported his pain to be 10 out of 10 along his shin and on the top of his foot. He was taking medications constantly, and he was hallucinating because of the pain meds as well, because of the pain and potentially the medications as well. His history and mechanism of injury: he was attacked and bitten by a dog a few years ago, and it required multiple ankle surgeries, and he subsequently developed unicompartmental arthritis. He had also just ran a half marathon 2 weeks prior to the surgery. He worked for the Greenville Police Department and was now working in the school system in internet security. And other than that, he had no other past medical history, and his goals were to be able to run and bike without pain. It's really important to note that the history and mechanism of injury, as well as the goals, all of that was collected after this initial evaluation. The patient was in so much pain, it was very difficult to collect any of that information here in this first visit. So basically, it was Jackie's main goal in order to just kind of assess him and make a determination of what the next step should be. So this is what his leg looked like. So you can see again, the calf is really swollen. You can see lots of redness here in the anterior leg, as well as lots of redness kind of into the foot. And I will say that having seen patients like this, I've seen patients before that have had the redness and swelling kind of down the leg and into the foot, and that's still been normal. But the problem here was with this patient was the way that they were presenting. So we would expect an individual would have lots of swelling, lots of pain, and kind of redness down the leg after the surgery. However, we don't expect them to kind of present with the pain that he was reporting, as well as the fact that he could not tolerate the physical exam at all. So he was unable to tolerate the skin being touched, particularly the area that was along his shin. His incision looked okay. He was able to do a quad set, but it was excruciatingly painful for him. He was able to move his toes, but it was excruciatingly painful. And he had questionable active motion at his ankle, which was also excruciating. So here's where things really aren't adding up. You know, at this point, we would expect for it to be painful, but not that he wouldn't be able to tolerate any of this at all. So Jackie decided that on her differential diagnosis list that she needed to include potentially an acute anterior compartment syndrome, that he had potentially developed some type of infection, or it could just be that postoperative pain and swelling. So with those things being on her differential list, given the fact that an acute anterior compartment syndrome and an infection both would have very negative consequences if left untreated or if we took a wait and see approach, she wanted to make sure that she referred this patient back to the physician. So here's kind of the history of events of what happened. He was in the clinic between 8 and 9, and that's whenever Jackie was able to perform the physical exam. At that point, she consulted with the clinic director because she just kind of felt like that even though that she was told that this patient would be painful, that she still felt like something wasn't sitting right with her. It didn't pass the sniff test. And she thought that she needed to further, have this patient screened. So the clinic director suggested that she contact another therapist that worked in the company that was very familiar with these procedures. So she did that. And she also consulted with the surgeon over the phone. So that was the plan, was to consult with a surgeon over the phone after she spoke with the therapist. So by 9 o'clock, she couldn't directly contact the surgeon. So she sent the patient home because the patient, she needed to get the patient back home with specific instructions to keep his phone with him at all times, and to have a ride arranged if possible to take him to Spartanburg, because that's where the surgeon was in clinic that day. The surgeon was not in clinic in Greenville. So at 10 o'clock, she finally was able to speak with the surgeon. And after speaking to the therapist on the phone, the therapist that had previous experience with osteotomies kind of shrugged her off just a little bit and said, this is kind of what you should expect. We expected, especially with this patient, that he was going to be a little bit more aggravated than normal. But instead of just accepting that, Jackie still just felt like something wasn't right. And so that's why she did persist and call the surgeon, make sure that she got in contact with the surgeon. When she spoke with the surgeon, she explained everything that had occurred. And I think that even in this particular case, the surgeon wasn't 100% convinced, given that Jackie hadn't seen patients that were post-op after the surgery before, but he was compelled enough to have the patient come to Spartanburg. And at that case, the patient came to Spartanburg to see the physical therapist that Jackie had contacted earlier, who was more accustomed to seeing these patients. And once the patient showed up at the clinic, that therapist then did about 20 minutes of soft tissue in order to decrease the swelling, to see if he could dorsiflex. And at that point, there was no change in his ability to be able to actively dorsiflex. So the surgeon was right next door, and the therapist went over and told the surgeon that it would be important for him to come over and take a peek, because this patient is an outlier, and we're concerned that something else is going on. And sure enough, something else was going on. By 4 o'clock, the patient was taken to the hospital for an emergency fasciotomy. So they were rushed over to the hospital in order to perform that fasciotomy, in order to reduce the pressure in that anterior compartment. And in the course of 5 days, he had to have 2 more surgeries. And then the incision was closed on that 5th day. So here's what you see kind of immediately post-op, what the leg looked like after performing the fasciotomy, where they go in and just open the skin in order to relieve the pressure. And then here you see what it looked like on day 5, days 1 through 5. So kind of a progression there, days 1 through 5. And unfortunately, this gentleman lost his anterior compartment in his leg. So they had to the muscles had died, and they had to go in and debride and take out the damaged tissue. So you can see that that anterior compartment is pretty much no longer functioning. So again, he lost his anterior compartment in the process of the debridement over the course of those 5 days. He did complete some home health for about a week, and then came back into the clinic. And at the next outpatient visit, that's really whenever they were able to actually get a history and assess his goals. And when he was working with Jackie, he shared with her that he did not remember the initial visit at all. But he already was presenting with excellent coping behaviors and kind of thinking positive, because he was a runner, and that was one of his goals, was to be able to get back to running. And he was already considering options for running with a special AFO, if that was going to be possible for him. And at this point, he was experiencing very minimal pain. So just from a treatment standpoint, kind of the first outpatient visit, the things that Jackie focused on were skin mobility and patellar mobility, dorsiflexion, range of motion, quad strength, and gait impairments as well, and addressing gait impairments and kind of teaching him how to use his crutches, because of the surgery was non-weight bearing, because of the high tibial osteotomy, was already needing to be non-weight bearing. And then also began working on some hip strengthening. So what were her lessons learned? So these were the things that she shared with the other fellow residents. So I think I failed to mention this, but she was a resident when this occurred. So she was probably 1 year out of school after this happened. So still kind of early in her career. And what she kind of learned from all of this is that a patient's subjective complaints cannot be ignored, even if they seem normal, until they are objectively evaluated. So in this case, when you're talking to a patient over the phone, especially after a surgery like this, you expect them to be in a lot of pain. And it can be difficult without seeing the patient to really understand if they are truly a 10 out of 10. This gentleman couldn't even tolerate you touching his skin. So that's